Good morning, everyone. Thank you, Dr. Arif, for the introduction, and thanks to Dr. Ayman for the organization, and thank you all for being here this morning. Today, I'll be talking about inborn error of metabolism in this metabolic disease session, and I'll be focusing on the laboratory approach to diagnose these disorders. So I have nothing to disclose, and let me, before starting talking about the tests that we use to diagnose inborn errors of metabolism, let me just define or remind you with the definition of inborn error of metabolism. So here we are talking about a group of mainly monogenic disorders that are commonly inherited as autosomal recessive. Now, some of inborn error of metabolism can be inherited as X-linked or as other ways of inheritance, but mainly here we deal with autosomal recessive. And usually in inborn error of metabolism, there's a mutation that impairs a certain enzyme that affects a metabolic pathway. Now, when we say metabolic pathway, we are talking about a series of chemical reactions that occur in a cell. Here I'm showing, I hope that the pointer is working. No, the pointer is not working. So basically in a metabolic pathway, thank you, Dr. Alail. Basically, we are talking about a series of chemical reactions. When we define a metabolic pathway, we are talking about a series of chemical reactions that characterize or that are happening in one cell and that are driving the change of a molecule from one shape or one molecule to another until and here we are showing the urea cycle that I will come to later when I talk about a group of conditions. Now, in molecular biology, the basic dogma or the flow of genetic information from gene to protein to metabolic pathway so that a normal function can occur is what makes us healthy. However, in case that the gene is defective and then the protein is affected so that a metabolic pathway is impaired, then the function will not be normal and then the disease will express itself. So this is the basic pathophysiology of inborn errors of metabolism. Now, the group of inborn error of metabolism exceeds 1,000 disorders that we are aware of, and these diseases, although they are rare individually, but as a group, they are really quite common. And here I'm quoting the 1 to 800, but probably there are even more. And as I indicated earlier, they occur due to a mutation in a certain gene that affects an enzyme or transporter. They can present at any age from fetal life to much older age, late in life. And they can be affecting one system or multi-system, and the presentation can be slightly confusing, and really we need sophisticated lab technique to tell that it's an inborn error of metabolism, it's not infection, it's not intoxication, it's not a vitamin deficiency, etc. And many of them can successfully be treated. And here is the importance, because we can treat them, so it's really important that we identify them as early as possible before the damage happens. And some treatments are life-saving, and then we require early detection, such as newborn screening. Now, when we should suspect a metabolic disease. So these disorders are usually suspected when there's a family history, of course. If a patient is presenting with encephalopathy or psychomotor retardation, behavioral changes, movement disorder, etc., or if there is a critical or catastrophic illness in a newborn, which is not supposed to be there, especially if it comes after a symptom-free period, and if there is poor response to treatment. So we are trying to treat the symptoms and they are not going away, and then that tells that there is something underlying this and then causing the poor response or causing an exaggerated response to a common illness. Now, patients with failure to thrive with dysmorphic features with developmental delay in general are suspected also to be worked up for inborn errors of metabolism. So again, let me go to the simple diagram where it shows the conversion of a substrate in a metabolic pathway into a product as driven by an enzyme and a cofactor. Now, if the enzyme or cofactor system is not working, there would be accumulation of substrate and deficiency of the product. And in some cases, alternative products will be formed. And these alternative products can be toxic. Now, to diagnose inborn error of metabolism, we either, or the standard way of looking at that is measuring the metabolite or measuring the enzyme and then confirming that with molecular. But in nowadays medicine, things have changed, and we could, because of the access to molecular technologies, then some physicians actually prefer to start with molecular and then confirm the inborn error of metabolism by measuring, the functional markers such as metabolites or enzymes. And of course, there's in between, some start with enzymes, as in the case of lysosomal storage diseases. So the diagnosis can be at any or using any of those approaches. And probably I'll talk today as a biochemical geneticist, starting from metabolite and enzymes. So now when the child who's suspected, or when the patient suspected with inborn error of metabolism is presenting, now there is really a wealth of information that could be obtained using routine laboratory techniques such as blood gases, electrolytes, glucose, ammonia, ketones, lactate, liver functions, complete blood count. So if we do this, we can really get a wealth of information that can direct our next step. And these tests are probably available with a quick turnaround time. Now, the history of the patient, family history, consanguinity, relatives with similar disease, the symptom-free period, all of this is very important when we decide what to do next and when we decide to work up as an inborn error of metabolism. Now, I'll be focusing mainly on the first five tests that can direct our testing strategy. So if a patient is thought to be, this is a busy slide and I'm not going to go through any of the names in this, but I just want to show you the complexity and the overlap between the various groups and individual disorders that can be presenting, for example, with metabolic acidosis and ketosis. So the acid-base balance in the body is disturbed, and then, as I showed in the previous slide, we see disrupted electrolytes and blood gases. So it could be an organic aciduria, fatty acid oxidation disease, could be plus ketones, could be minus ketone. So this could be so confusing without using a certain algorithm to decide what test we should go to first. So if a patient is presenting with metabolic acidosis, we look at ketone plus ketone without ketone, and then we can go through the algorithm to find what is the diagnosis. However, the key word in this diagram would be urine organic acid analysis, plasma amino acid analysis, and acyl carnitine analysis. So these are the three main tests that we rely when we do testing in biochemical genetics lab environment. So in this diagram, the most important thing that I want you to remember is that when we do plasma amino acid, when we do urine organic acid, when we do plasma acyl carnitine, it can narrow down our search to an individual condition. And the next group of disorders are those that present with hyperammonemias. Now, in hyperammonemia, it could be primary, caused by urea cycle disorder, or it could be secondary to an organic acidemia or fatty acid oxidation disease or a mitochondrial disorder. And hyperammonemia algorithm, again, is extensive, and you will always find urine organic acid, plasma acyl carnitine, and the plasma amino acid at the key steps in this differential. And once we do this, we can tell which disorder among the extensive list I showed in the previous slide is the condition with the patient. And again, this is the group of disorders that can present with hypoglycemia, the mainly fatty acid oxidation disorders or carbohydrate disorders, or even some organic acid ureas. And again, we use the similar algorithm to tell which disorder are we dealing. Now, for practicality, I'll show you a case or a couple of cases where we go through and see what can we do using the main three tests that I was talking about, or I indicated: plasma amino acid, urine organic acid, and acyl carnitine. So the first case, and this case was actually a case of Dr. Ayman Al-Hattab kindly shared with me. So it's a 3-day-old boy. It's important to know that it's a boy. Here, he was brought to the emergency room with lethargy, poor feeding since the morning. Apparently, the child was doing well in the previous 2 days of their life. He was born at term, uncomplicated, and discharged in the second day of life, and then he was okay. So the patient was doing well in the first 2 days, and then things got complicated in the third day. Now, the baby boy was on breastfeeding every 2 hours, but since this morning, he did not suck, or he was sleeping all the time. So this tells you that something is really ongoing. And then the parents are non-consanguineous. And this is important here to know that although there is no history of consanguinity, some disorders can be inherited, not necessarily in autosomal recessive. And in this case, the mother's sister lost a baby boy at the age of 7 days, and that was presumed to be sepsis. So this history is really very important to guide us through this case. Now, on physical exam, it was not really telling much, except that the baby was tachypneic with tachycardia and hypothermia, and otherwise he was okay, but with decreased movements and with some hypotonia. Now, as I said, the first line of testing is to do your basic biochemistry test, and in this child, the glucose, ketones, and liver functions, lactate were all normal. So this puts you, yeah, that's okay. So some of the disorders have been excluded here. However, the blood gases showed some alkalosis with low PCO2, and bicarbonate was also low, and further testing of ammonia showed extremely high ammonia for the age group. This is respiratory alkalosis, and then probably many of you now would know what the diagnosis is. So here we are dealing with a hyperammonemia. So where does this ammonia come from? So ammonia comes from the metabolism of amino acids. So it's the removal of this amino group here. And amino acids can either come from dietary proteins or can come from the catabolic processes in our body. And because unlike fat, proteins and amino acids cannot be stored in our bodies. So they have, unless they are utilized, they have to be excreted. So the urea cycle function to remove ammonia quickly, because as was indicated by other speakers yesterday, ammonia is neurotoxic, and our bodies have to get rid of it quickly and should not accumulate. The primary process or pathway that gets rid of ammonia is the urea cycle. And the ammonia is incorporated in urea cycle through a multiple enzymatic steps until it's excreted as urea, and then the cycle goes between the mitochondria and the cytoplasm. The enzymes that are involved in urea cycle are numerous, and the main ones are CPS1, carbamyl phosphate synthase type 1, OTC, arginosuccinic acid synthase, arginosuccinate lyase, arginase, etc., etc. So any of those enzyme deficiencies could cause the hyperammonemia and the picture that we are seeing in our patients. Now, the key amino acids to look at when we are looking at hyperammonemia or when we are working up hyperammonemia is basically mainly citrulline. Citrulline could be high or low, and high tells us a few things. When it's low, it tells us about other things as well. And also we look at arginine and ornithine, glutamine, etc., etc. Now, this is an amino acid profile. It shows you the peaks of every amino acid separated, and then the x-axis, of course, is time, and the y-axis is intensity. So we can tell how much of a particular amino acid is there based on the peak height and the time that an amino acid, a typical amino acid chromatography test takes is about 2 hours when using cation exchange chromatography. In this case, our patient had decreased citrulline. Okay, and here is the urea cycle again, and here is citrulline. So when citrulline is decreased, it's really a proximal part of the urea cycle is what is impaired there, that the synthesis of citrulline is not working properly, because had the defect been here or here, then citrulline would have been high. So in this case, citrulline was low, then this could be an OTC deficiency or CPS deficiency, which are the two enzymes that are involved in the synthesis of citrulline. So we looked at organic acid in this child, and we found that orotic acid is high, and orotic acid actually comes from the metabolism of carbamyl phosphate. So this means that this enzyme is intact and is working, and then orotic acid became high, whereas citrulline is low, and this tells us that here we are dealing with ornithine transcarbamylase deficiency, which is an X-linked urea cycle disorder, and that goes with the rest of the story that we said it's a boy, and then the sister of the mother had another boy who has the effect. So this really makes the whole story clear. Now, this is a list. Again, we are not supposed to go through everything here, but I just want to show you the extent of disorders that can be detected by amino acids. So these are the urea cycle, these are the aromatic amino acid disorders like PKU, tyrosinemias, MSUD, non-ketotic hyperglycemia, and so on and so forth. So a large number of disorders can be detected with one test. Let's now move to the next case that I want to illustrate the use of those three laboratory tests: plasma amino acid, urine organic acid, and the plasma acyl carnitine. And again, thanks to Dr. Ayman for giving me this clinical scenario. Here we are talking about another newborn, 5-day-old female, presented to the emergency room with 1-day history of poor feeding, very non-specific presentation. And of course, parents in this case were cousins, and this is their second child. The first child was healthy, and this tells you that, yes, it could be metabolic, and the patient was pale again, tachypneic, tachycardic, and lethargic with weak cry and hypotonia. And all of this is still non-specific. However, on testing their blood gases, he showed some acidosis, some degree of acidosis with low bicarb and slightly elevated lactate, and pancytopenia with all indices being low. And ammonia was elevated, but not as elevated in the previous case, which was a primary urea cycle case. Here we had also high ketones. So then we are looking at a case with metabolic acidosis and hyperammonemia with elevated ketones, and of course, would suspect an organic acidemia. Now, the nurse who was taking the blood from this baby to do the testing noticed that there was a smell in this baby. So, and the smell was a sweaty feet. Now, we know that several organic acidureas have those characteristic smells like mousy smell, musty smell in PKU, boiled cabbage in tyrosinemia. I don't know what boiled cabbage smell is actually, but they say it's boiled cabbage. And here they are saying it's sweaty feet. I'm not sure what sweaty feet will smell like, but that's what it was said. And these are, you will see them a lot in metabolic books. So in this case, the disease is obvious. Probably when we say sweetie fit odor, and that's isovaleric acidemia. Now, to confirm isovaleric acidemia, we look at urine organic acid and acyl carnitines, and this is the organic acid profile. You see the huge peak here of isovaleryl glycine, which is the characteristic hallmark pathognomonic marker for isovaleric acidemia. And when we did the testing for acyl carnitine, we noticed this very high peak at 302, a mass to charge ratio of 302, which indicates the accumulation of isovaleryl carnitine or C5 carnitine. And here the concentration was probably 100 times elevated, and all ratios of C5 carnitine to any other carnitine, whether it be C2, C3, C4, is really high. So this was a very straightforward of an isovaleric acidemia case. Now, the group of disorders that can be detected with organic acid, urine organic acid testing, is really extensive. Again, you can see methylmalonic acidemias, propionic acidemia, all cobalamin disorders, glutaric, isovaleric, a large number of organic acidemias. In some disorders, urine organic acid can be helpful, like in PKU. It's not truly diagnostic, but you can see markers of PKU, maple syrup urine disease, MCAD, very long chain, VLCAD, many other disorders can be seen in a urine organic acid trace. Now, in this list, this is again not to be read, in its entirety, but these are many other newly or recently described inborn error of metabolism that can be seen in urine organic acid. So again, it's a single test that can tell you a lot of information. And we have recently seen amino acylase deficiency, for example, in urine organic acid, where unusually inacetylated amino acids can be seen. Now, the next group of disorders that can be detected with the third technique that we spoke about, which is the plasma acyl carnitine, is the fatty acid oxidation diseases, where we can detect a huge number of them, starting with the carnitine cycle, the carnitine uptake defect, CPT1, carnitine palmitoyltransferase, CPT1, type 1 and type 2, CAC, it's very long chain, 3-hydroxy-acyl-CoA dehydrogenase. So all those disorders that belong to the group of fatty acid oxidation, and they usually present with hypoglycemia, with hyperammonemia, can be detected by a simple test of plasma acyl carnitine profiling. So this is my last slide. What I just wanted to highlight in this presentation is that, yes, inborn error of metabolism are extensive group. They are overlapping. They can rarely be specific presentation. Usually it's always very overlapping, very non-specific, very unspecific. However, we can use basic laboratory tests such as electrolytes, blood gases, ammonia, glucose, and if you have the choice to take 5 tests, I would say blood gases, electrolytes, ammonia, glucose, and ketones, probably in this order. Take them, do them, and this will really direct you and narrow your search. And then plasma amino acid, urine organic acid, as well as plasma acyl carnitine will tell you the diagnosis. And that's all for today. Thank you very much for your attention.